Let's discuss the principles of automated anterior vitrectomy in this patient who had a PCR during epinucleus removal. Let's understand what is the difference between the cut IA mode and the IA cut mode of the vitrectomy. In the patient that I'm about to discuss, the nucleus management was uneventful. Accidentally, while removing the epinucleus, as you can see, there was a localized punched out tear in the posterior capsule. Following a viscofluid exchange, both instruments were removed from the eye. And this is the situation we are left with: a tear in the posterior capsule and the entire epinucleus still in place. Let's now see how we managed this case. Some more dispersive viscoelastic was introduced into the anterior chamber to keep the vitreous away, after which I went with the bimanual irrigation aspiration and attempted to remove the epinucleus. Intermittently, I had to keep injecting some dispersive viscoelastic in the anterior chamber overlying the rent. With care and caution, I proceed with the removal of the epinucleus and the cortex. I'd like you to observe the irrigation held in the left hand. I always maintain the irrigation towards the angle. With the aspiration held in the right hand, I proceed to remove as much of the cortex that I can from the inferior and the left half. Having removed as much of the cortex and the epinucleus as I could, I then perform a viscofluid exchange. I'm going to now attempt a viscodissection of the superior epinucleus. Having managed to prolapse the epinucleus towards the center, I now proceed to aspirate it. As I proceed with the aspiration of the epinucleus, I can notice that the underlying tear seems to be enlarging. So I remove the aspiration cannula and perform a viscofluid exchange to prevent any vitreous herniation. This is my final attempt at attempting to remove some of the epinucleus and the cortex. At this stage, you can notice that the rent has become fairly large. There doesn't seem to be any disturbed vitreous, but we still have some amount of a residual epinuclear sheet between the 12 and the 4 o'clock position. In order to ascertain the presence or the absence of vitreous, I inject some diluted triamcinolone in the anterior chamber, after which I wash it. There seems to be a vitreous prolapse towards the right paracentesis incision. Note at the outset, we cut the strand of vitreous that's prolapsed outside the eye. Next, with the irrigation introduced through the right side port incision, the vitrectomy cutter is introduced into the anterior chamber and starts to cut the vitreous, initially from within the wound and then from the anterior chamber and finally in the area of the posterior capsular rupture. This cutting of the vitreous is done in the cut IA mode. The cut rate can be anywhere from 800 cuts per minute to even up to 2000 cuts per minute. The vacuum is limited at 150 millimeters of mercury. And as you do know now that strands of vitreous almost always prolapse in the area of the least resistance, that is typically towards the incisions, watch how I go and cut the strand which is prolapsing out through the main incision, and then the next one which tends to be prolapsing out towards the right paracentesis incision. A good guide is that sometimes you will see a notch in the PCR signifying that that is the area where the vitreous is prolapsing. Having cleared all the disturbed vitreous, it's now time to address the residual epinucleus and cortex. For that, we use the IA cut mode. Here, we mainly rely on the aspiration of the vitrector to hold, draw out and then aspirate this cortex. So with the IA cut mode, it's the irrigation, the aspiration and finally the cutter. So whilst aspirating the cortex and the epinucleus, should you find a strand of vitreous, from the aspiration you can further depress the foot pedal, go to the vitrectomy and cut that strand of vitreous, after which you can go back to the aspiration to remove the cortex. In the same manner, the inferior cortex is removed by now introducing the vitrector on the left side and going in the IA cut mode of the vitrectomy to remove the inferior residual cortex. The residual cortex from the 4 and 5 o'clock position are removed after retracting the iris with the irrigation itself. This now completes the removal of the cortex, the epinucleus and the disturbed vitreous. Having achieved this, it's now time to implant the monofocal IOL within the capsular bag. Why did I choose a monofocal IOL? Because I have a fairly localized central tear in the posterior capsule. So having introduced the IOL within the capsular bag, I now rotate it to assume a horizontal position. Having completed the insertion of the single-piece monofocal IOL in the capsular bag, a careful and a gentle visco wash is done to remove the viscoelastic from the anterior chamber. No excessive rock and roll movements should be made of the IOL in a compromised case like this. Following the completion of the visco wash, the aspiration cannula is removed from the eye, the paracentesis in the main incision is hydrated, and finally the right paracentesis incision is also hydrated. A last quick check by injecting some triamcinolone in the anterior chamber, and we can clearly see that the anterior chamber is completely free of vitreous. And this then finally is the end result that we achieved. I do sincerely hope that you found this video tutorial useful. Thank you.